I'm Dr. Jeremy London. I'm a board-certified cardiovascular surgeon, and I've been in clinical practice for over 25 years. Today, we're going to talk about how a patient with normal cholesterol can still have a heart attack. And you've probably heard this story multiple times in various formats. Now, I do want to clarify before we jump in that what we're talking about today is heart attacks that are a result of atherosclerosis. There are a small to moderate group of patients who have heart attacks for other reasons, be it coronary spasm. The coronary artery can temporarily clamp down and cause a heart attack. You can have embolic events or pieces of clot come from other areas in the body into the coronary arteries. There are a multitude of other non-atherosclerotic causes of heart attack. And we're not going to get into any of those today because they can get somewhat complicated, but the important thing is they don't belong in this discussion because we are going to refer to the ones that are related to blockages as a result of cholesterol. Now, here's the story that I feel like most of us have heard in one form or the other. You have a patient in his 50s, goes to see his doctor, gets his lab panel back, everything is normal. They shake hands. Doctor says, you look great, feeling great. And 18 months later, that same patient is in the back of an ambulance having a heart attack. The second patient is same age, 50, 55, but had abnormal cholesterol for a long time, but has been on a statin. And his cholesterol is really, really, really low, like that of a young 20-year-old. He's doing his thing. Same patient in the back of an ambulance 18 months later again. What's the explanation in these two scenarios? And quite frankly, they're both wrong. Scenario number one, my cholesterol was normal. Here I am having a heart attack. Clearly, cholesterol is a myth. Cholesterol is wrong. Cholesterol is not related to heart attacks. Very popular on the internet, very popular on social media. Absolutely a wrong answer. Number two, here's a guy who knew he had abnormal cholesterol, took his statins, drove his cholesterol way, way down, and still had a heart attack. His response is, my cholesterol is low, I'm on a statin, and I'm safe. Also a wrong answer. And the truth of the matter is the actual answer lies somewhere in between these two, quite frankly. And my goal today is that by the end of this podcast, you understand why someone with normal cholesterol can still have a heart attack, that cholesterol is not the whole story, that the majority of the risk factors that culminate in heart attacks are actually controllable, and most importantly, that you're not an average, you're not a population study, your heart is your heart, and all of this has to actually be personalized to you. We would like to take a minute and thank our sponsor of this podcast episode, Function Health. Health isn't just what you see in the mirror. It's also what's happening inside your body. Knowing which biomarkers are in and especially out of range establishes your health baseline instead of guessing. Function Health is an all-in-one health platform that offers 160 plus lab tests, ranging from heart health, hormones, early-stage cancer detection, toxins, and vitamin deficiencies. Function offers 5 times more testing than the standard primary care panel. This level of blood work would normally cost thousands of dollars out of pocket, but with Function Health, it's a fraction of the cost. Scheduling is simple. With 2,000 plus lab locations across the U.S., and most visits last about 15 minutes. Once your results are ready, you will receive a clear, comprehensive summary from Function's clinical team. With real data, you can take action, retest over time, and track whether what you're doing is working. If you're interested in the blood panel my family and I get every 6 months, head to functionhealth.com/London to sign up for less than $1 a day. That's functionhealth.com/London. Now let's get back to the podcast. Let's unpack cholesterol. But before we do, before I unravel all this, I want to make sure you know what is true, because the last thing I want is for you to step away from this podcast thinking that cholesterol isn't important, because that is not the case. Cholesterol is causal for heart disease. That is well proven. The burden of evidence is undeniable, and the treatments for it make a big difference. That is scientific fact that we certainly can lay our hats on. But that's not the whole story. And the fact is, we really need to dive deeper here so that we understand, and I use the word really lightly, I don't want it to sound overstated, hidden in the cholesterol panel. And I want to start with the first factor, which is ApoB, or apolipoprotein-b. This is not something that is included on a standard primary care panel, but basically what it measures is the atherogenic or dangerous particles that are circulating in your blood, your dangerous cholesterol particles that actually cause the damage, that actually can penetrate the wall. So why is this important, and how is it actually measured? Well, think about it like this. If cholesterol is being carried by trucks on the highway, the LDL number is the total load of cholesterol that's being transported. The ApoB, or the dangerous part, is the truck. It's the number of the trucks. So think about this a bit. You can have the same load of cholesterol in 3 trucks. They're packed to the gills, so not a lot of dangerous cholesterol there in comparison. Or you can have a similar load of cholesterol with smaller amounts loaded in many trucks. So the amount of dangerous cholesterol is actually significantly higher. And that explains why 2 patients can have the same LDL number with extremely different risk profiles. And so what ApoB does is it gives you a much more granular understanding of what your actual risk is. Where are the dangerous particles? Where do you lie on that spectrum? So that we can truly understand your cholesterol panel better. The second factor that is typically not measured on a standard panel is something called lipoprotein A, or what I'll refer to as Lp(a). This is an inherited or genetic type of cholesterol that is passed down, and 1 in 5 individuals actually have this. It is also an atherogenic particle, and it is in fact picked up by ApoB when we measure it, but it is a little different, and here's why. Because it's genetic, we really can't modify it very easily with diet or medications at this point, and it has an added factor that not only can it penetrate the wall, cause an inflammatory response, and start the process of building a plaque or blockage, but it also causes clotting or thrombosis. And those 3 things together are really a setup for increased risk of heart attack. So these are 2 components that live underneath this LDL number that we're really not looking at completely. Just to be complete, as we talk about the dangerous cholesterol particles, and I'm just going to touch on this, is that when cholesterol is broken down in the body, there are remnants of cholesterol that are also dangerous particles. In addition, obviously, things like triglycerides and other factors on the lipid panel are certainly factors. But when we're talking about what's hidden behind cholesterol in particular, ApoB and Lp(a) are really the 2 factors that help us optimize defining risk. Normal LDL doesn't mean optimal LDL. And that's really crucial. Let me say it again. A normal LDL, because it's compared to the population and to averages, does not necessarily mean optimal LDL for you. So what's the takeaway here? LDL does not tell the whole story. I want to give a brief overview of like a 30,000 foot view of what is happening actually within the blood vessel when these plaques or blockages develop. And it's really two major components. You have things that attack, factors that attack and penetrate the vessel wall. They set this process in motion with inflammation, clot formation, and consequently cause a blockage. And then you've got the other side of the equation, which is the health of that endothelium or vessel wall that prevents that penetration. And then the things that you can do that decrease the amount of attackers and increase the health of that vessel wall. Well, we reviewed prong number one, which is the LDL story, ApoB and Lp(a), the atherogenic or dangerous portions of it. Now what I want to do is move into prong number two. And here's the interesting thing about prong number two. It's not hidden like the LDL story. These are things you're familiar with. These things may seem quite simple in some respects, but the interesting part is that the vast majority of heart attacks can be prevented by controlling risk factors that you can actually mitigate with good lifestyle choices. We want to take a minute and thank the sponsor of this podcast episode, Rora. Now, hydration is truly foundational for our mental and physical performance. The problem is that our tap water may contain contaminants that can be harmful to our overall physiology. These chemicals can disrupt hormones, fertility, and even your gut microbiome. In fact, 95% of U.S. water systems tested positive for at least one carcinogen. That's why last year our family started using the Rora countertop system. In my opinion, Rora makes the best water filters on the market. Rigorously tested by NSF, the Rora filtration system is proven to remove lead, forever chemicals, microplastics, and 50 other contaminants. And unlike other filters, Rora removes harmful substances while keeping the beneficial minerals like magnesium and calcium in your drinking glass. It takes less than 5 minutes to set up, and it looks great in your kitchen. If you want to start filtering your water with Rora and save 25% on your countertop system, head to rora.com/London. That's RORRA.com/London. Now let's get back to the podcast. Let's jump into prong number two and look at the lifestyle modifications and the risk factors that go along with those that make up the majority of heart attacks that we see. Most of this information comes from a very large study, the INTERHEART study, that looked at about 30,000 patients. And they really wanted to answer this very simple question, and that is, of the risk factors that cause heart attacks, which of them are controllable with medications and lifestyle changes, and which ones are totally out of our hands? And they defined a very specific series. It was 9 specific factors, and we'll go over those in some detail. But it was very interesting that they came up with a number at the end of this. The conclusion was that 90% of heart attacks could have been prevented with risk factor modification. Now, I'll address that number once we look at the study in a little more depth, but that was the conclusion of this study. And I don't think that really any of these risk factors are going to be surprising. The first one is cholesterol, but looking at cholesterol the right way, they measured ApoB, number 1. Number 2 was smoking. Number 3 was interesting. It was stress as the third risk factor that we can modify. And the fourth, and this kind of included a bunch of subcategories, is what they called metabolic cluster. And I'll read to you what that was. It was diabetes, high blood pressure, abdominal obesity, things that affected your metabolic physiology. They put in basically into one category. And then they looked at the things that were protective, that if you eat well, if you exercise, if you modulate your stress, if you don't smoke, you're at a a healthy weight where your waist to height ratio is less than 0.5, that you can mitigate these risks. And they found that these risks were not additive. They compounded, they multiplied. And when you have compounding risk, the sword actually cuts the other way as well. That's why if you have smoking and high blood pressure and diabetes, your risk goes up dramatically. The same is true if you modify these risks by eating well and paying attention to your sleep hygiene program and minimizing stress. You get exponential decrease in your overall risk. So this is a very powerful piece of the puzzle. Again, looking back at those two patients that were in the ambulance, very similar scenarios, but cholesterol was not the only risk factor that was sitting in the room there. These are incredibly powerful. Now, let's look at two things that are related to the setup of this study, because if you go and look at it yourself, you're probably going to question this as well as I did. 90% is a big number. Well, the truth of the matter is the study's been redone. They looked at very similar factors as the INTERHEART study, but their numbers came out more in the 55 to 75% as far as the number of heart attacks that were caused by modifiable risk factors. And looking at the additional studies, I think the number probably falls somewhere in there. Nonetheless, that is a dramatic number. And if we can move the needle, we could really move the needle on taking cardiovascular disease, heart attack, and stroke from the number one cause of death worldwide down the list. Two more things that I want to address related to this study and this whole idea about risk factor modification. First is the INTERHEART study specifically addressed that moderate alcohol intake was beneficial or protective from a cardiovascular standpoint. And that has essentially been reversed with recent investigations, that really no amount of alcohol is cardioprotective. One of the other things that is not addressed in these studies is genetics. And clearly that's because it's something that we can't necessarily modify. And as I always say, you can't run from your genes. And that is very true. But genetics is an important factor when we're looking at cardiovascular risk. Family history is incredibly powerful. If your father, uncle, mother, first-degree relatives have had coronary disease, that is a powerful risk factor for you. We touched on a genetic risk factor earlier of Lp(a). You can't fix that, at least right now. And there's other things too. There's other types of cholesterol metabolism, inherited disorders that give people very, very abnormal cholesterol levels early at birth. What's my point here? Knowing your genetics and knowing your family history is not a sentence, it's intelligence. And knowing it, even though you might not be able to change the thing you know, really gives you an opportunity to stack the deck in your favor, to take control of all the things you can take control of. Drive your cholesterol numbers down, pay closer attention, be more thorough, be consistent with your exercise, control all of the things you can control. This isn't about becoming fearful as a result of your genetics. It's about understanding the hand that you've been dealt and how exactly you're going to play that and what your strategy is going to be moving forward. One of the things that I really want you to remember as I'm giving you all of this kind of hardcore scientific data, because that is what it is, it feels like it's going to affect everybody equally. And the truth of the matter, that's really not the case. We all have our own physiology. We all have our own heart. We all have our own vascular systems. And each risk factor, although it may be weighted in one way or weighted in the other way, may affect you differently than it affects your neighbor. Y'all may have the same cholesterol. You both have high blood pressure. You both are ex-smokers, and one of you has bad heart disease and the other one doesn't. That doesn't mean that they're not risk factors. It means that we're all different and that we have to understand all of these things in context, and that this information is really important to discuss with your physician and understand how the hierarchy works for you. Really, what we're playing here is a game of probability. We're trying to maximize our benefit and minimize risk. And understanding the basic physiology and pathophysiology and what causes blockages in the artery. That first prong, what's attacking the artery? ApoB, Lp(a). Remember, LDL is still an important number, but it's those atherogenic particles that attack the vessel wall, can penetrate it. Those are the ones that make the difference. Then we have the lifestyle factors on the other side, that all of these things are what really push us over the edge the majority of the time to actually end up having a heart attack. And these are the things we actually have control over. And understanding these and knowing your numbers and having intellectual honesty about where you fall on the risk profile is what's going to enable you to figure out what's most important for you, for your physiology, for your heart, not your neighbor's heart, not the average of numbers, not the population studies. Those things are all important to develop the framework, to develop the protocols. But it's understanding how those protocols need to be applied to you to maximize the benefit and minimize the risk of cardiovascular disease. Thank you so much for your time today. I certainly appreciate it. If you enjoy this type of content and you want to do a deeper dive, check out our free newsletter. We'll drop the link below. If you've been watching on YouTube, you can like and subscribe. If you've been listening on Spotify or Apple Podcast, you can leave up to a 5-star rating. Please follow as well. This will notify you of future episodes. Thank you again for your time and attention, and I hope you guys have a great day.